Thank you, Kara. Thank you. Thanks for the invitation and thank you for the kind introduction as well. Welcome everybody to the talk. I'm going to attempt to share my screen now. It worked a second ago and it works again, I hope. Does it work? Perfect. Thank you. Yes, so maybe not here. Yeah, so as Kara kindly introduced me, I'm usually doing different kind of things than the project I'm going to talk about today. So I am currently at the University of Manchester as a lecturer or assistant professor at the Department of Social Statistics, and also part affiliated with the Mitchell Center for Social Network Analysis. But that's really an informal thing here. My background is in sociology originally, so I was one of Karo's students in 2009 or so, while he was the supervisor of the project, that was my first social network data collection, which focused on multiplex networks and network dynamics in Hungarian schools. And since then, I've through my PhD and my postdoc years, I've been analyzing these kinds of data, and I've been interested in modeling social networks and social network dynamics, with the aim of understanding how relationships evolve and how they change in schools, so among students or among teachers, and how these affect really individual and group level outcomes, such as mental health or academic achievement. So this is what I've been doing, and this is what also led to a different project in Switzerland when I was a postdoc there, and I'm generally intending to continue this here in Manchester as well. But as Kara said, I just arrived 2 years ago, and in the meantime there was a pandemic, but I also became a dad, so it's been all just very confusing. So I haven't really been able to kind of start up anything new here. I'm just trying to finish what's old. So relative to all this, what I'm going to talk about today is something completely different. It's about malaria and how people choose or not to protect themselves against mosquitoes who might carry malaria-bearing parasites. And this project has a bit of social networks in them, but nothing of the heavy modeling that I've done in the past years. But it's refreshing to talk about something like this. I hope that I can live up to the expectation that was set by the excellent speakers before me in this series. So the focus of the talk will be about the role of social networks in the adoption of different measures, how people can protect themselves against malaria mosquitoes in a certain part of rural India. And so this project is actually part of a bigger study that is led by researchers from New York University, from the Center for the Study of Complex Malaria in India, SCSCMI. So Jane and Annie there are the ringleaders in this research, who have a very good overview of malaria research and needs for future further examination in India. And the collaborators involve people from the Indian Institute of Public Health. It's Sandra and Rajiv and Matini, who are basically people in the field, so they know very well the context from where our data is from. And the third leg of this collaboration is the University of Manchester, where Elisa Bellotti, one of my close colleagues in the Mitchell Center, is the co-investigator of this project, and she represents a kind of social network expertise that the PIs and the other investigators thought would be interesting in this project. And the paper I'm presenting today is a close collaboration with Elisa. So she is the first author of the paper. So much of the nicely rounded arguments are her doings, And she has participated in the data collection. So she actually went to the Meghalaya state of India, where the data was collected, and went to some of these villages to interview people about their social connections and how they protect themselves against malaria mosquitoes. So she actually has a lot of field knowledge. And of course, she trained other interviewers who then went to different villages to collect more data for us. So really what I'm going to talk about is, well, the nice parts are mostly Elisa's work, actually, and the weaker parts will be my contributions to the analysis of the data. So the outline of the talk is pretty standard. So first, I'm going to talk about the motivation for us to do this study and what we aim to achieve. Then I will introduce the data and methods that we use, show the results, and discuss mostly what still needs to be done. Because at this stage in this paper, we really need to think about what else needs to be done. So, and of course, sorry, I forgot to mention this, but if you have any questions during the talk, which are very pressing, then if you can use the chat, so I can probably see that, or yeah, you can just wave or give some kind of signal, raise your hand, and I see that there's a question, and I can stop. But you can also ask questions at the end. So to continue about the background and the motivation of this study. So as I said, the main idea is to study how people protect themselves against malaria mosquitoes, and this is a part of a bigger battle against malaria all around the world. So actually, what we have seen in recent decades is that the reduction, there's a generally huge reduction in malaria cases across well, the parts of the globe that are affected by the disease. Since 2000, and also in India. So there's the occurrence of malaria has been massively reduced, and so much so that the World Health Organization is now planning to completely eliminate the disease by 2030. So in less than 10 years. And if you have seen the news, just recently the WHO started to, I think, recommend the first ever vaccine against malaria. So there has not been a vaccine for malaria before. I think it now exists and is now showing well in trials, and they would like to use it soon. But of course, it's going to be probably years before it can be rolled out. And we know nowadays how much trouble it can be to get a population vaccinated, especially so big as, for example, the population of India or other states where this is relevant. But until then, until we have the vaccine, we of course still need to continue the work. And even though there's been massive reductions in the occurrence rates of malaria overall, there are many local epicenters, and these are often rural and hard to reach populations who live somewhere in like these wet, rainy areas in hills or mountains where it's difficult to get to them. So these are always like also very specific contexts, which the experts now recognize require targeted interventions, often ones which involve local populations. So basically, somehow you need to get the people who live in these areas to cooperate well with the state, with each other, to somehow get rid of malaria. So how does that work? The key tools in the fight against this are different preventive measures. So what this focuses on is preventing mosquitoes which may carry the parasites to bite people. So that's the, well, it's super easy. So it's just physical defense against malaria. So you shouldn't get bitten by a mosquito and then you're safe, right? And in the 2010s in India, good results have been achieved by the state distributing two kinds of protective measures. One was indoor residual sprays. So these are just usual sprays that you spray on walls. And these tend to repel mosquitoes who like to land on walls and rest there while they are feeding. I think we all know this kind of thing, when a mosquito is on our bedroom wall and then it looks for us, waits for us to fall asleep, and then it starts buzzing around the head. So these repellent residual sprays basically just repel the mosquitoes, and then they can't rest, so they are going to leave the house or just don't come in anyway. And these sprays usually last for about 2 to 3 months before you have to do this again on your walls. And the other thing, the other measure that they distributed in the 2010s was this bed nets, long-lasting insecticidal nets that you hang above your bed while you're sleeping, so the mosquitoes can get in. And they also have insecticide in them, so it kind of repels the mosquitoes. And these bed nets have proven to be effective for sometimes for 3 years. So these are really long-term solutions. And what they did in India is that in states where this was malaria was an issue, they distributed to every household these bed nets and these sprays. And I think they probably keep doing this as well. And this was very effective. But it also created other problems, or at least it pushed the problem to a different place. So once the mosquitoes, which are the main viral vectors, so are the carriers of the parasite that causes malaria, since they couldn't really feed indoors, where they on the one hand started to adapt to this and started to feed outdoors. And also, obviously, there are many species of mosquitoes, and well, the species that were mostly like feeding indoors have now been kind of reduced by these measures. And the bigger problem are species which are, for example, living in fields where people work, and so on. And to protect against these, there are many other preventive measures that can be used. So, for example, there are insect repellent sprays that you can spray on yourself, or body creams which have similar effects. There are also these coils which you can see on the top left little figure here, so that you can light up and then they burn and give a specific scent which kind of repels mosquitoes and sometimes also humans. And then a very typical practice in these parts of India that we are focusing on is burning different materials. So sometimes cardboard boxes or boxes for eggs and many other things. You just burn them and the smoke basically drives away mosquitoes. It turns out that quite a few people are doing this as a more traditional way of repelling mosquitoes. And also, of course, clothing is very important, especially if people are outdoors in the mornings and in the evenings when mosquitoes mostly feed, or when they are working in fields. And you can generally wear protective clothing, and also choose to, for example, just wear boots or gloves which protect your hands and feet against mosquito bites. So these are the main preventive measures, and you can see that all of them are focused on just not letting the mosquitoes bite people. And so the question is, still nowadays, and especially in these pockets of infection, whether people use these measures, and who are the people who use them. So how can we identify which are the people who are willing to use more of these measures and thereby acquire higher protection against the mosquito bites, and who are the people who don't. And so maybe we can then figure out how we can nudge people to protect themselves more. And one thing that has been identified by earlier research is that, of course, these measures need to be affordable and easy to use. And we are often talking about low economic status areas, so it has to be, these things have to be really cheap, and mostly they are, and often they are. And now it restarted, perfect. So that was just a glitch. Yeah, so the affordability and ease of use is not really a general issue. It has been shown, so when people don't use these, there might be other reasons. And earlier research, not always focusing on India, but sometimes on different countries like Bangladesh or countries in Africa, like Cameroon, I think, but maybe that was something else. Anyway, I rather don't say anything. So studies from other countries have identified that there are individual and household level factors which can be associated with the use of these different measures, such as socioeconomic background or knowledge about the disease. So people who know that malaria is a disease that is spread by the mosquitoes are more likely to defend or to use these tools to prevent mosquito bites, of course. But this is not self-obvious or not self-explanatory, because in many of these settings that we are focusing on in this empirical study here, we have tribal settings where many people or some people might not know exactly about how this works, or they might know about it but might believe in something else. And there was another factor, is like religion is sometimes associated with the use of these tools, either because maybe by some local religious beliefs, it may be that you don't think that malaria is preventable. So that's also something that has been seen, or maybe your religion doesn't really, by some sort of religious belief, you don't want to use one tool or the other. But anyway, most of the relevant research here focuses on individual and household level factors. And less is known about the role of social networks in these contexts, and how they can be used, or they can be leveraged to change people's behavior, so to convince them to use as many protective tools or preventive tools as they can. So probably many of you know this, but just a quick slide. So social network analysis is can be seen for us here as an approach, both theoretical and methodological, which studies social systems as a set of actors, for example, individuals, who are connected by different sets of social ties. And this approach looks at how social ties and the behaviors of actors are interdependent. And what SNA is aiming to do is that it would like to infer social processes from the observed patterns of behavior, attributes, and network ties. So we try to figure out what might have led to the outcome that we are observing. And so on the right here, you can see an example that I'm going to talk more about these, of course. So this is from one of our villages from India, and then the size of the nodes. So each node is an individual, and the size shows how many different ways they are, how many different tools they use to protect against mosquito bites. So the bigger the circle, the more kind of seriously they take protection against mosquito bites. And then the question can be, and so that the ties between them are communication ties. So who do they discuss health issues with? And so the question can be whether the behavior, so protection against malaria, is somehow related to who you are connected to. And this is what we are trying to uncover here. And so to put that in a theoretical perspective, so we could say that we are dealing with kind of a diffusion of behavior situation, right? So we need, for example, people to get to use, I don't know, coils to protect against mosquito bites. How can we diffuse this behavior in the network? And so one way the literature suggests is by leveraging social influence, right? So that people somehow influence other people's behavior. And we are looking at this in the most simple way, that we think that, okay, if certain people are using some preventive measures, then this will make more likely that I am also using them. And one part of this, or one practical way how we can imagine this is happening is through peer effects. So there are informal social ties connecting people. For example, in these villages, some people talk to each other about health-related things. Among them might maybe about protecting against malaria, mosquito bites. And these ties can be channels of influence or learning. So these can be ways how people can learn about the effectiveness or the niceness of using certain kinds of measures to protect against malaria. And the other approach is of opinion leaders. So you can think that, okay, maybe not everybody matters who you talk to, but there are a few influential actors in your village, for example, who may have an effect on what you do. And in this picture on the right, there are two colorful nodes, the red and the blue, and there will be influential actors in the villages. And as you can see, they are also quite central in the discussion networks. But of course, they are they might have some influence outside of the network. So at this point, we just think that in order to inform later or future interventions, which aim to convince people to use different measures to protect against malaria, we need to identify who are the effective champions. So who would be important to convince that a new measure, or maybe perhaps a vaccine, makes sense to use or to take up, right? And so the question is whether this would be the person who is, or would this be the colorful persons, influential people in the villages, or would they be certain people who are well connected informally? Yeah, so this is something that we would on the one hand hope to find out. So some key concepts of network studies. I'm just going to go through this if we are interested in studying behavior change. So first of all, we need to have clear population boundaries because social influence may happen through pathways that leave the same goal, and that's not a good thing. So we would like to have a population defined where most of the informal, for example, discussions about health-related issues are happening within the boundaries. So for example, for us, the population boundary is a village. So we will focus on people in villages. And I will also show you later how this is, how good a boundary this is, just visually. It seems that maybe it's not so great, but it's kind of good. And then another important thing is coverage or participation. Then, since we have network data, another important concept here is the dependence of observations. I see why Kara might have turned on his video. My internet connection was unstable. I hope you didn't miss much, but I basically just went through these bullet points. I'm not going to go back because they are not quite crucial, and you can see the main point here. So what's important as well in an SNA study of behavior change is the dependence of observations. So we have a network connecting villages. So everybody's behavior can be dependent on everybody else's behavior, which means that some of the standard statistical models that we would use might not be suitable for analyzing this kind of data, or they might be, but with complications. One more thing to keep in mind in such a study is that we are dealing with exposures to opinions of others. So as I mentioned earlier in the examples, if you learn about what your peers do through talking to them and using these social ties that you have, this may affect your behavior. And then, as I mentioned as well, there can also be opinion leaders. So maybe if you have contact with influential people, that might have an extra impact on your behavior. And these influential people can be, for example, like local nurses. So much for the background. Now, one slide about the aims of the study. So in this backdrop, what we are trying to achieve here is to understand what are the important factors that are correlated with the use of malaria preventive measures. And we have data from 6 villages from the northeastern part of India. Preventive measures. And then our second question is, or the second aim is to evaluate the role of social networks in this. And on the one hand, we would like to know which network features explain behavior. So is it, for example, the number of people you talk to? Or is it then the ties that you have to certain opinion leaders? Or is it the behavior of your peers? What matters in networks? And our second question about social networks is whether they are more important or less important or equally important in explaining behavior as individual characteristics. So the characteristics that are usually studied in these contexts. Right. So a few words about our data and methods. So our data comes from, as I said earlier, from the state of Meghalaya, which is in northeastern India. So it's in this enclave between Bangladesh and Nepal, and like that's the little part of India that kind of sticks out. And this is what you have here in, so it's one of the states there, just on the border with Bangladesh. And you can see the whole state on this map here. So this is in general a hilly rural state. About 3 million people live here in this entire state. And it generally has wet weather, so conditions are ideal for mosquitoes to spread malaria. So this is one of the problem areas, or some areas in this state are problematic still in terms of malaria, although not as badly as they were 20 or 30 years ago. And most, well, in the villages that are here are, the inhabitants are typically tribal communities, and some of them are maybe matriarchal is not the right term, maybe that's something else, but generally the women are considered to be the heads of the household, not always, but often. And it's always the girl children who inherit the land, for example. So I think it's the youngest girl who will inherit the land, take care of the parents once they get old. So it's these are kind of, they are different communities than the ones we might be accustomed to living in. And they also have an interesting parallel of modern and traditional health systems. And this is manifested by, well, two positions that exist in most villages. One is called the ASHA, accredited social health activist. And so that's basically kind of a local nurse or somebody who has an understanding of modern medicine and who are accredited to be the local GPs or whatever in villages. And the other figure is the healer, the traditional healer who is, well, who represents the tribal traditions of medicine as well as other methods. So what we see in the empirical data is that not always, but in some of the villages, that the ashas and the healers seem to be at odds. So it mostly is the asha, so the modern medicine representative who uses more tools to protect against malaria themselves against malaria, and healers use fewer. But the difference is, well, it varies. So then, of course, it can also be an interesting point whether some people consider the ASHA to be a trustworthy source of information about health matters and relevant matters for us, or the traditional healer, or both, or neither. Yeah, so the design of the study, even though I'm talking a lot about social influence, but I'm going to stop doing that now because now I have to admit that this is really a cross-sectional study. So unfortunately, collecting this data, so going to the villages, interviewing every adult villager has taken a lot of time. Also, it was impacted by the pandemic. So there were long periods when data collection was not possible. So we got data from 6 villages in 2 regions of the middle and the eastern region of the state. And these were collected over a period of 1 year, and every respondent was interviewed once. So unfortunately, going back and repeating the interview was not possible because, well, in scope of this study, but of course that would be probably the next step. So all we are dealing with here are really correlational findings. So we can just look at well, patterns that suggest there might be interesting relations going on, perhaps between networks and behavior. Yes, so the villages were selected, well, based on convenience, really. It was a convenience sample, where not all villages had official resident records, but the ones we selected had them, because then we could make sure that we tried to interview everybody from the list of residents of the village. And they were also chosen to have a feasible size fieldwork. So most of them are between 70 and 150 people. So we didn't have the capacity to interview hundreds. So these are smaller villages. So our target population was in the end about 1,400 individuals who were living in 640 households in these 6 villages. And you can see that the response rate on the right, it varies a lot. And the orange or brownish bars are the response rate among the adult population, so the individuals, and the other one is, that's interesting, is the household. I'm wondering whether it's possible that the household one is smaller in the first one. That might be a glitch there, but anyway, so in some villages where the response rate on the individual level wasn't very great, as you can see, but at least mostly the response rate on the household level is quite good. So anyway, we have this. We might decide to exclude at some point a village because of low response rates, but not for this analysis. So the data collection was carried out by interviewers who were trained, visiting every house in the village and conducting in-person interviews with everybody above 18 years of age. There was a standardized questionnaire that they went through, which asked about individual characteristics, about the adoption of 8 different preventive measures that I will list in a second, and about villagers' social networks. So one question about networks was who they talked to about health-related matters inside, in their village and outside. So it can be that there are cross-village ties. And a similar question, but about who they avoid talking to. So there was also a negative question, and I'm sorry to say, but this network is not going to be part of the analysis that I'm presenting today. We tried to use this, but in some villages we didn't have this data because this question wasn't asked, and in other ones it was the network was so sparse that it didn't really seem to carry enough information or introduce enough variance. So as usual, people don't like to talk about their negative feelings towards one another, but we are sure that they have them. So we then ended up from each village getting 2 kinds of networks, and I'm now not talking about the positive and negative 2 kinds, but there was a full network and the reduced network. And the full network, seen on the left side here, contains the people who were interviewed and also anyone they named in the network question, so any alters. And so on the left side, the red people are, the red circles are the interviewed people, and black squares are people who they mentioned but who were not interviewed. And so they were either not interviewed because they were not part of the village, so they were from another village, or they were not interviewed because they couldn't be reached or refused to interview. I think that was very rare, that somebody refused to answer questions. What happened most often is that they were not in the village physically, and that's because some people spend certain amount of time every year working in another village or in a town or in fields somewhere. So this is what so happened often. So they are not there, but they are somewhere where they are meeting other people from other villages. And we thought that it's important to keep them in the network pool, even though we don't know about their individual characteristics, but they might be important sources of information from outside village, right? So maybe it's important to treat them as to count them at least like as number of contacts. And on the other hand, we have the reduced network on the right here, which just contains the interviewees yeah, and then this is an example where you can still see the negative ties, which are the red ones, and they are mostly centered around, in this village, around the Asha and the traditional healer. So they are also like focal points of declared negative ties, which also is a reason why we didn't include negative ties in the end, because having variables identifying the Asha and the traditional healer were enough to capture this. Yeah, so the dependent variables are, well, we have 9 of them actually. So we have information about the use of 8 different preventive measures. One are the bed nets that I mentioned earlier. There was also, number 0 was the spray for the walls, I think. No, wait. No, number 0 was any kind of net. Maybe not the insecticidal, but everybody uses that, so that wasn't really there was no variation there, so we are not trying to explain that. But we have the bed nets, which have insecticide on them. We have protective clothing during the evenings and mornings, wearing boots when working in the fields, and wearing gloves. We also have insecticide creams, coils, vaporizers, and burning materials. So these are the 8 measures that we are concerned with. And the 9th variable that we have is a sum of the measures that people use. So it becomes a kind of a linear, well, a count-dependent variable, where 0 is that they don't use any of them, and 8 is that they use all 8 of them. And we have a bunch of explanatory variables that we can use in explaining behavior. So on the table on the right, we can see the individual, on top we can see the individual variables. So we have gender, age, which we use as categorical. Then whether the respondent is a head of the household, whether they are looking after sick people, so whether that's their role in their family or maybe even regarding neighbors. Their educational background. Yeah, you can see the categories there if you're interested, and whether they are working in fields or not. So not everybody has a job in fields, but some do. Then we have a bunch of relational variables. The first one is, well, the first 2 are different exposure measures, which can be maybe imagined on this hypothetical extract from the network on the left. So the first exposure variable is the average number of preventive measures used by people in somebody's discussion network, right? So you can, for example, on the top right corner, you can see that there's an individual who names, in the middle of that little star there, who names 3 others. And for each of those 3, you can count how many of the 8 measures they use. And then the exposure is then the average of this number across the 3 others. And then we can check how much this is associated with the number of measures that an individual, him or herself, uses. And the other exposure variable is what we use for the explaining the uptake of the individual protective measures. So it's actually more meaningful here on the left, which is an example where we see that gray nodes don't use a certain measure, and maybe you can even see what they don't use. Adoption of coils. So this is about the little burning coils. And the little figure on the top right of the graph shows that the focal actor, the middle one, uses coils, and it has 2 relational partners, 2 authors who use coils and 1 who doesn't. So for this individual, we can say that 2/3 of their network uses coils. So then we can try to correlate this with whether they use coils or not. Right? So this is the other kind of exposure that we have for the binary outcome variables. So how many, or what's the percentage of your network that uses a given type of measure? And besides these exposure variables, we also use variables capturing the size of your discussion network. So how many people you report talking to among the interviewees, so among the little network, and outside, right? And so as I said, these can be, the outside people can be people from other villages and people who are in your own village, but who are away, working in fields or working in other villages. And so we think that these 2 can be counted together because they represent sources of information, maybe about preventive measures, outside of your village. And the last 2 relational variables that we use are whether you talk to the ASHA, so whether you talk to the kind of the modern nurse or GP, or whether you talk to the traditional healer. And of course, both can be true or neither. So these are also representing possible effects from the 2 figures. Yep. So these are the variables that we consider in our analysis, and the methods we use. So yeah, I'm going to talk a bit about the different methods that we have tried and that didn't work. So at the moment, we are looking at a crazy multi-level data set. So we have 2 districts of the state, so the middle one and the east one, And we have villages, like three villages coming from each of the two districts. And each village has some households in it. And each household has a few interviewed individuals. So some households have one adult who was interviewed. Others have two, some have three, and it's rarely more than three, I think. So maybe sometimes you get 4 adults living in a household, but it's mostly like between 1 and 3. And beside that, you also have the alter, like the ego-alter connection. So you have the networks in each villages, which are cross-cutting with households. So this is at least a 3-level cluster data structure, nested one, which is cross-cut by the network dimension in the village level, right? So it's a bit complex, and at the moment we are trying to get away with it by doing a mixed effects linear model and some logistic models, which only have random intercepts. So probably if you know about multi-level models, then I assume that your blood pressure is rising at the moment. This is not going to change. So actually, I will be very thankful if people have good suggestions about improving the analysis that we do. But so what we have and what we have done. So to analyze this earlier, we tried to do village level autologistic actor attribute models, which are the offshoot of exponential random graph models to explaining individual outcomes or behavior. So this is implemented in the MPNet software, by the way. So it's a bit similar to logistic regression, but then you can incorporate explanatory variables which reflect network ties and exposure to people in your network. And then these different parameters will be estimated following an NCMC-based estimation, which is the same as how exponential random graph models are estimated. But we found that it's very difficult to find anything with these models because the networks are not so big, and in some of the measures there isn't a lot of variation in some of the behaviors. So it seems to be there's a lack of power there. So then we tried just village level normal regressions, where we use best subset variable selection, right? So basically we tried every possible combination of variables that I listed in the previous slide and tried to find the best ones. But still, it seems that power is not quite enough for these, and there are always very small subsets of variables identified. So being head of the household, your education, and 1 or 2 network variables were left in the model, and we kind of lost this ability to nicely show how certain groups of factors are contributing to the explanation of behavior relative to the other ones. So it seemed that the village level data is not quite great or big enough to get what we want. We also tried to include negative ties, so similar measures like I talked about, like but to the avoidance network. So not like talking to the usher, but avoiding the usher. How many people do you avoid, and so on. And these networks, as I mentioned, were too sparse, so we couldn't really get anything out of them. So our conclusion at that point was that we need some sort of data pooling across the villages, which led us to multi-level regression models. But before I talk about those, I just quickly power through some descriptives. So overall, what we these are the individual characteristics, descriptives by village. So overall, what we see is that where the villages are quite similar in some respect, but they have differences. For example, in how many people work, how many of the interviewed people work in fields. So there are some villages where this is as high as 80%, whereas in others it's around 50, 60. And also we have differences in the distribution of education level. So there's that middle village there, the third one, where only very few people have below primary education. The other ones are much higher. So typically around half of the people are have education which is below the primary level. Yeah, otherwise the age distribution seemed quite different. The male-female ratio quite similar. Also male-female ratio seems quite similar. yeah, so that's just to have a bit of an idea of the context. Now, if we look at the outcome variable where we count the number of measures that people use, these have, well, in the first 2 villages, this is on average around 2.5. So people use 2, 3 of the 8 measures concurrently. And then the other 4 villages, they use between 3 and 4, closer to 3 perhaps. And I will also present the distribution here in a second. Now, if we look at the adoption rate of the 8 measures separately, then we see that there's quite a bit of difference in these measures. So there are some, like the bed nets, that were, if you remember, these were distributed by the government. These are used by almost everybody, or many people, really. Also, many cover up, but at a slightly lower extent. Boots and gloves are used by much fewer, and this is partly due to the fact that these are mainly useful when you work outside in the fields, and not everybody has a job that involves working outside. Creams and vaporizers are perhaps the ones that are most rarely used, also because these are more expensive. The little smoking coils, there's quite a bit of variation. So in the eastern region, more people seem to use these. I think that's, than in the central region. But this might just be not a systematic difference, really, because we are just having a few villages in our same boat. And you can see that burning materials is kind of done by every 3rd respondent in all 6 villages. So it's quite a bit of difference in between the different measures. Now about our social networks. So these are the 6 very colorful networks that we're looking at, and these are now not very informative as they are. The colors are representing households, and I think maybe they are also recycled. So this is definitely something that we have to keep working on. But so what you see is that the average degrees in the discussion networks are typically, well, in the most villages are around 2. So you report talking to about 2 others related to health issues, except for the 3rd village, which is not the, it's in the bottom row, it's the 3rd one, because I put them in a weird order. So the 3rd village, where people report talking to on average 4 others. But as you can see, these are mostly centered around the Asha and the traditional healers. So they are the ones who really get many of these connections. Whereas this is not so intensely the case in some of the other networks, but in some, yes. So in any case, we see that as usual, there are some similarities, but these networks look also a bit different in every village. Now about the linear multi-level model. So we are now explaining how many of the 8 measures people are using to protect themselves against malaria. What makes this possible and not highly illegal is that the distribution of the outcome is, well, it's close to normal. You can say it's kind of symmetric. So it's definitely not very much skewed to one end or the other. So that's why we thought that a linear model is a good first approximation. And what it tells us is, first of all, that there's a huge variance coming from the household level. And the other thing is that females may be using somewhat fewer measures, but not by a lot, so by 1/3, so like by 1 maybe on average. And that if you talk to more people who are outside your village, then you are more likely to use somewhat more your village, then you are going to use 1 additional measure. I was probably off a bit again, but I just said that we have an effect here from female and an effect from talking to people outside your village. Now moving on to the logistic model. So we also built the same models with the same multi-level structure, explaining the binary outcome of whether you use each of the 8 measures. And this table just shows the significant outcomes or the significant estimates. And it seems that one thing that seems consistent is that exposure, so how many people in your discussion network use the given measure, has a positive effect on you using the same measure, right? So if more of the people you talk to use for cover up, for example, then you will be more likely on average to also cover up to protect against mosquitoes. And also talking to people who are not interviewed, so who are spending time outside your village or live outside your village, is associated with a higher likelihood of using some of the measures that we looked at. Now, one question that may arise is how good these models are at explaining the outcomes. Well, they are not super good, but also not very bad. So when we use single level multiple regression for the linear outcome, which I didn't show you because that would have been clearly wrong, what we found was that about 2% of the variance was explained by individual factors, whereas it rose to 12% if you included also the network variables or the relational variables. And I'm just showing this because we have seen something similar when we looked at the multi-level regression. And what I tried to do here is to decompose the R squared to like how well is the outcome explained if we only just consider the random effects, versus when we only consider the fixed effects, which is a very tricky thing to do and probably isn't quite correct. But at this point, I believe that it would work, and the takeaways are quite similar. So you can see here that the first model that we tried included just demographics, and the dark part of the part of the variation in the outcome explained by just the random effects. So assuming that we have the random effects, what we have, and we set the fixed effects to 0 as if they were non-existent, then how much of the variance can we explain? And that comes to about 60%. And most of this is the household variance, actually. So there's so much variance between households, and this is now fitting a different intercept to groups of 2-3 people. So actually that helps a lot in explaining the outcome. And relative to that, the demographic factors, the brighter part of this rectangle, they explain very little. So about 1 or 2%, as in the single levels and the networks. We see that where the part that is explained by the fixed effects is bigger. Again, it roses to around 10%. And what's odd and confusing is then we have the bigger model, which has the lower R squared. But of course, this shouldn't be that surprising because we have this multi-level model where we added a lot of fixed effects. So it is possible, and it suggests that maybe this is not a great model specification that we're working with. But we are investigating how to make this better now. And just as a comparison, I also put here a third model where I have demographics and networks, but we don't have the household level random effects, random intercept. And that again demonstrates that, well, the explained percentage of the outcome, explained variance of the outcome drops, showing that it's really the household variation that explains a lot and not a variation between villages, for example. Now we try to do a similar thing to the logistic models, but with, of course, accuracy of, well, prediction, but not really prediction, but like just within the data set. And there were a bunch of very confusing results here. So I'm not going to show everything here to you. Rather, I will continue to the discussion where I return to these, well, methodological challenges that we're facing at the moment. So first of all, what we learned from the study is that, well, these bed nets are most commonly used in our sample, which are no surprise because they are regularly distributed. Then more easily accessible and cheaper preventive measures are next, and creams and vaporizers are most commonly used. And other studies suggest that it's because they are costly and they are not very practical. But we didn't find a systematic difference across all these measures between the two regions. So it seems that the two regions we survey are very similar in terms of rates of adoption. Then in terms of the role of individual characteristics, when we look at our different models, we find some inconsistent evidence that individual characteristics matter here, like women use fewer measures, and we see that or then those who look after sick people cover up less when they are outside, which is reasonable. Again, I might have dropped out for a second. Sorry, I hope these are not very long. And then we also find some evidence that people who are working in fields cover up more and you use gloves, boots, and bed nets more often. All this seems to make sense, so it at least gives some face value to our results. So maybe methodologically there are still things that we need to improve a lot, but at least we are not really torturing and twisting the data so much, hopefully. However, it seems that the individual characteristics explain little of the variance in the behavior. Then about the role of social networks, we found that exposure to peers who use preventive measures has a positive association with the use of the same measures or the number of measures. And also talking to more people who live outside or spend time outside the village has again, a positive association with the adoption of some of the measures. We find limited evidence of the role of opinion leaders, so the usher and the healer. They don't seem to be consistently impactful or correlated with, talking to them is not systematically correlated with higher likelihood of use of certain preventive measures. And it seems that these factors might explain behavior more than the individual ones, but with, of course, with the large remaining household level variance, it's very difficult to tell. And just a few last words about work that we need to do to make this into a decent study, because, well, I think that the data that we have is really valuable, but we just need to sort out a few details. However, the whole approach that we followed has a number of limitations. The first is that we have self-reports, of course, and they may not reflect true behavior. Then our network question is rather vague, that we asked in the interviews. So it's about discussion of health-related matters, which may not include malaria or malaria preventive measures at all, or in some cases it might not. So we don't know that. Then, of course, we have this cross-sectional design, which only allows correlational results, but we think that this might be, well, at least we now have a blueprint for doing a similar study, which is longitudinal in the future, and also we can suggest certain things to investigate further. Well, of course, the modeling is currently a work in progress limitation because our specification and model choice is still quite not great, and we need to improve on this. Now, there are a bunch of things that we were planning on still doing. So maybe we have to move back to village level regressions or some sort of pooled multi-group regressions to find the right balance between the size of villages and also between power and like the right model specification. Then we received a suggestion earlier that we should consider data aggregated on the household level, and we need to investigate that, which would probably make sense. Also because of the higher response rate on the level of households. Then we still need to come up with a better way of comparing how important individual and network variables are. And I would be very happy if we could also test not just the or we could assess not just the training error, but also the test error. So if we could do some cross-validation of the results to see how well our models would do imaginarily in a different context. And of course, I think one very, very big open question is how much the network, how much we can assume away network dependencies by fitting these multi-level models. So what is left of network dependencies after we have all these variables in the models? So that's something that we might be able to assess using ERGMs, but we haven't gotten to it yet. And in the longer term, and maybe that will be a different paper, I think we would be very interested in doing some simulation studies, starting on this cross-sectional data set with of course, serious assumptions, which can help to understand how new measure would be adopted by villages, and how interventions can help the widespread adoption of a new measure. For example, the possible malaria vaccine that might be in distribution in a few years. Yeah, that's all I wanted to say, and thank you very much for your attention, and I'm looking forward to any questions or ideas. Thanks.